Priyanka, will you start?
Yes, sir. Good evening, sir. Good evening, ma'am. And good evening, everyone. I'm Dr. Priyanka. I completed my MD anesthesiology and I'm working present in Queen's NRI Hospital, Vizag. Today, my topic is acute severe pancreatitis. Before going to the topic acute pancreatitis, let me give a brief introduction about pancreas. Pancreas is an abdominal glandular organ with both exocrine and endocrine function. With the exception of tail of pancreas, it is a retroperitoneal organ located deep in the upper abdomen in the epigastrium and left hypochondrium region. Pancreas divided in, as we all know, pancreas divided into head, body, tail, and head, neck, body, and tail. Pancreas secrete 1500 to 3000 ml of isoosmotic alkaline fluid per day, and these secretions are rich in enzymes and bicarbonate, which are needed to perform the major digestive activity of gastrointestinal tract and also to provide an optimal pH. So coming to acute pancreatitis, the last four letters itis itself indicates inflammation. So it is an acute condition of diffuse pancreatic inflammation. Now coming to etiological factors, the two most common causes of acute pancreatitis are alcohol and gallstones, accounting approximately about 75 to 80% of cases. Coming to all other causes, we can remember these causes by the mnemonic I get smashed, where I stands for idiopathic, G for gallstones, E for ethanol, T for trauma, S for steroids, and M for mumps, any viral infection, most commonly mumps, A for autoimmune disorders, S for scorpion sting, H for hyperlipidemia or hypercalcemia, E for endoscopic retrograde cholangiopancreatography, and D for drugs, which include azathioprine, loop diuretics, thiazide diuretics, tetracyclines, estrogens, and salicylates. Now coming to pathogenesis, as we discussed, this pancreatic enzyme are rich in, this pancreatic juice is rich in enzymes. Normally, these enzymes are in inactive form within the pancreas and they get activated once they reach the duodenum. But due to all the etiological factors we discussed earlier, like pancreatic duct obstruction, either due to gallstones or by tumor, or hyperstimulation of pancreas, either with alcohol, triglycerides, or if there's any defect to intracellular transport, or any sphincter of body dysfunction. Due to all these etiological factors, there is an increase in intraductal pressure or direct acinar cell injury. Whenever there is a direct acinar cell injury or increase in intraductal pressure, the junctional barrier between the acinar cells break down and the release and the enzymes in the acinar cells, they get released into the interstitial space. When these enzymes get released into the interstitial space, they get activated within the pancreas, causing autodigestion of pancreas. So whenever there is an autodigestion, our body, our immune system get activated to clean up this debris. And in this process of cleaning up, our inflammatory cells, they release many cytokines. And these cytokines, they are released into the circulation, causing capillary leakage, decreased effective circulatory blood volume, causing hypotension, and finally leading to multi-organ dysfunction and death. So so we can discuss the pathogenesis in three phases. First phase is all about the autodigestion of pancreas due to all these etiological factors. And second phase is about activation of this immune system and release of inflammatory cytokines. And third phase is all about action of these cytokines on the distant organs. So now patient presented to us in an emergency department. So these most patients with acute pancreatitis, they present with sudden onset, severe abdominal pain in the epigastric region, which is constant, radiating to back, lower abdomen and flanks, which get aggravated on supine posture and relieved on leaning forward, which is known as tripod position, which is associated with nausea, vomiting, and abdominal distension. Coming to signs, in central nervous system, we see decreased GCS, and cardiovascular system, hypotension, mainly due to capillary leakage, tachycardia to compensate that hypotension. And in respiratory system, any rails present, and tachypnea present. And as it is an inflammatory process, fever is also present. On physical examination, abdominal tenderness, guarding, ascites present, jaundice present if there is any extra hepatic biliary obstruction. Now, there are two signs, there are Cullen sign and Great Turner sign. If there is an ecchymotic discoloration around the umbilicus, it is known as Cullen sign. And if this ecchymotic discoloration is present around the flanks, it is known as Great Turner sign. They both suggest retroperitoneal bleeding. Okay, with these clinical symptoms and signs, we have other differential diagnoses. So we should differentiate acute pancreatitis from all other these differential diagnoses. Some of the differential diagnoses are as follows. In cardiac, it may be due to myocardial infarction. Coming to respiratory, it may be due to pneumonitis. In GIT, it may be due to perforated peptic ulcer or acute intestinal obstruction or acute cholecystitis, metabolic diabetic ketoacidosis, acute renal colic, etc. So in order to differentiate this acute pancreatitis from all these differential diagnoses, we need to do some laboratory investigations. So some of the laboratory investigations are as follows. The two most important laboratory investigations are serum amylase and serum lipase levels. Serum amylase and serum lipase are both elevated early in course of acute pancreatitis. Amylase has shorter half-life of 10 hours and it returns to normal within 3 to 5 days. Lipase elevation lasts longer than compared to amylase. It returns to baseline within 8 to 14 days. And serum lipase is more specific and sensitive than amylase for diagnosis of acute pancreatitis. So if serum amylase or serum lipase is more than 3 folds above the normal, it is considered as acute pancreatitis. But the point to be remembered here is there is no correlation between severity and degree of this enzyme elevation. So that is about serum amylase and lipase. And LFT, if there is any extra hepatic biliary obstruction, these LFTs may be raised. Coming to blood pictures, there is leukocytosis. And due to this capillary leakage and decreased effective circulatory blood volume, there is hemoconcentration. And coming to blood glucose, due to decreased insulin production and increased glucagon production, there is hyperglycemia as glucagon is an acute phase reactant. So there is increased production of glucagon leading to hyperglycemia. ABG shows hypoxia and due to loss of bicarbonate ions, metabolic acidosis, and due to hypoperfusion and hypotension, increased lactate. And the most common electrolyte abnormality is hypocalcemia, mainly due to intraperitoneal saponification of calcium by fatty acids in the area of fat necrosis. And due to this hypoperfusion, kidneys also get affected. So there is increased blood urea creatine ratios and also blood urea nitrogen levels. As this is an inflammatory process, all the inflammatory markers like serum LDH, procalcitonin, serum CRP get elevated. As we discussed that serum hypertriglyceridemia is a cause of acute pancreatitis. So in order to rule out that, we need to order for serum triglycerides. Now coming to radiological imaging, if the patient presented to you with severe abdominal pain and he has elevated amylase and lipase levels, imaging is not required for the diagnosis of acute pancreatitis. It generally gives an idea about what is the cause of acute pancreatitis. So coming to radiological imaging, X-ray abdomen. This X-ray abdomen may show gallstones or sentinel loop. Sentinel loop in the second picture, the first arrow indicates the sentinel loop. Sentinel loop means it is an isolated distended bowel, isolated distended loop of bowel seen near the site of inflamed tissue. And in the second picture, the second arrow shows colon cutoff sign, which indicates the abrupt cutoff of colonic gas shadow due to inflammation. The X-ray show this calcified gallstone, calcified mesenteric lymph node, sentinel loops, colon cutoff sign. And ultrasound is also mainly useful to diagnose the etiology of acute pancreatitis, to detect gallstones, biliary obstruction, and serial assessment of pseudocyst. We'll discuss about pseudocyst in the next slides. And before discussing CT scan, we need to know that acute pancreatitis is of two types. One is interstitial edematous pancreatitis. Second is acute necrotizing pancreatitis. What is meant by interstitial edematous pancreatitis means it is a diffuse inflammation of pancreatic and peripancreatic tissue with enlargement of pancreas. There is no necrosis in this condition. Whereas coming to necrotizing pancreatitis, it is the necrosis of pancreas and peripancreatic tissue in addition to inflammatory changes. So on CT scan, if it is an interstitial edematous pancreatitis, it appears as homogeneous enhancement. Whereas necrotizing pancreatitis on CT scan appears as non-enhancing areas. So coming to CT scan, this first picture shows homogeneous enhancement of pancreas, which is acute interstitial edematous pancreatitis, whereas the second picture shows non-enhancing areas, which indicates necrotizing pancreatitis. So revised Atlanta classification has for pancreatic and peripancreatic fluid collections. So there are four types of fluid collections: acute fluid collection, necrotic collection, pseudocyst, and walled-off necrosis. In this, acute fluid collection and pseudocyst, they both come under interstitial edematous pancreatitis, and necrotic collection and walled-off necrosis, they comes under necrotizing pancreatitis. Then what's the difference between these? Or in the acute fluid collection, the duration is less than 4 weeks and there is no encapsulation. Whereas pseudocyst, the duration it occurs after 4 weeks and it has a well-defined wall, and they both included under interstitial edematous pancreatitis. Where coming to acute necrotic collection and walled-off necrosis, they both include under necrotizing pancreatitis, but the duration of acute necrotic collection is less than 4 weeks and walled-off necrosis generally occurs after 4 weeks. Here also, there is no encapsulation in acute necrotic collection, but there is a well-defined wall in walled-off necrosis. So based on this, we have a CT severity score. It is also known as Balthazar scoring, where it is divided into 5 grades: A, B, C, D, and E. Where A is normal CT scan. B is if there is a focal or diffuse enlargement of pancreas, we'll give it 1 point. C, it is pancreatic and peripancreatic inflammation. So then we'll give 2 points. D for fluid collection in single location. E is fluid collection in pancreas and even adjacent to pancreas. In this way, we score that. And if the score is 0, it indicates there is no necrosis. And if the score is 2, it indicates it has that 0 to 30% of necrosis. And the score is 4, it indicates 30 to 50% necrosis. And 6, it is more than 50% necrosis. So till now we discussed the symptoms and what are the based on the symptoms, what are the differential diagnoses and how we differentiate acute pancreatitis from all the differential diagnoses based on the laboratory investigations and radiological imaging. Now we are going to discuss about severity. How do you assess the severity of pancreatitis? Because assessment of severity is very important, because to detect high-risk patients, because the clinical course after an episode of acute pancreatitis is quite variable, and it is of utmost importance to detect high-risk patients who will progress to severe necrotizing pancreatitis in an effort to improve their outcomes. So this assessment of severity, we have multiple scoring systems. There are Ranson's criteria, revised Atlanta grade of criteria, Apache 2 score, Bishop score, and CT severity score, which we discussed before. First of all, coming to Ranson's criteria. Ranson's criteria is mainly divided into 2 types. If our etiology is biliary or gallstone etiology, or if your etiology is non-biliary or gallstone etiology. First, if our etiology is, if the cause of the pancreatitis is non-biliary or non-gallstone, then we'll look into these factors. If the patient at the time of admission age more than 55 years, or WBC count more than 16,000, blood glucose more than 200 milligram per deciliter, or serum LDH more than 350 units per liter, and serum AST more than 250 units per liter. And after 48 hours of admission, if there is decreased hematocrit of more than 10%, Increase in blood urea nitrogen of more than 5 milligram per deciliter. If patient we already present with we already discussed there is a hypocalcemia. So if calcium levels less than 8 milligram per deciliter, if PaO2 less than 60 mmHg, base deficit more than 4 milliequivalents per liter, and fluid sequestration of more than 6 liters. These factors are we need to look for these factors only if the cause of the acute pancreatitis is non-biliary or non-gallstone. If the etiology or if the cause of pancreatitis is biliary or gallstones, then we need to look for these factors. At the time of admission, age need to be more than 70 years, WBC count more than 18,000, serum glucose more than 220, AST more than 250, and LDH more than 400. After 48 hours of admission, drop in hematocrit of more than 10%, blood urea nitrogen of more than 3 milligram per deciliter, calcium same, less than 8 milligram per deciliter, and PaO2 same, less than 60 mmHg, base deficit of more than 5 milliequivalents per liter, and fluid loss of more than 4 liters. Based on this, if the risk factor, if the score is 0 to 2, the mortality rate is less than 1%. If the score is 3 to 4, it is 15%. And if the score is 5 to 6, the mortality rate is 40%. And if the score is 6%, the mortality rate is 100%. So based on this, we diagnose the patient into, we diagnose the severity of patient. Now, another scoring system, which is revised Atlanta scoring. In this, the severity of pancreatitis is divided into mild, moderately severe, and severe pancreatitis. Mild pancreatitis, there are no local complications or no systemic complications. Whereas moderate pancreatitis, there is transient organ failure, but it resolves within 48 hours. Whereas in severe pancreatitis, the persistent organ failure for more than 48 hours. Now coming to third criteria, that is BISHOP, which is bedside index severity of acute pancreatitis, which includes B for blood urea nitrogen more than 25 milligram per deciliter, I for impaired mental status, and S for systemic inflammatory response, which are defined. Systemic inflammatory response means if the they have 4 features. Out of, if there are more than 2, it is known as SIRS, which is core temperature less than 36 or more than 38. If heart rate is more than 120 beats per minute, if respiration rate is more than 30 per minute, and white cell count more than 12,000 or less than 4,000. In this 4, if there are 2 or more than 2, it is known as systemic inflammatory response syndrome. So are they. And in BISHOP, coming to A, it is age more than 60 years, and P for pleural effusion. Out of these 5 factors, if there are more than 3 factors are present, then it is considered as acute severe pancreatitis. Actually, in revised Atlanta score, we discussed about organ failure. And this organ failure, we can assess by using modified Marshall scoring. By assessing 3 main systems: cardiovascular system, respiratory system, and renal. In cardiovascular system, if systolic blood pressure is less than 90 and heart rate more than 120 beats per minute. Pulmonary, if PaO2 less than 60 mmHg, and in renal, if serum creatinine is more than 2 milligram per deciliter. In these 3 systems, if more than or 1 or equal to 1 is present, it is considered as organ failure. So these are the scoring systems. Based on this Ranson scoring or revised Atlanta scoring or BISHOP scoring or modified Marshall scoring, we need to assess the severity of pancreas. Now coming to complications, as we already discussed complications before, like pancreatic or peripancreatic fluid collections, like acute fluid collection or pseudocyst, which comes under interstitial edematous pancreatitis, or acute necrotic collection or walled off necrosis, which comes under acute necrotizing pancreatitis. So these are the local complications. Coming to systemic complications, central nervous system, it may be psychosis, fat emboli. Cardiovascular system, as we discussed, there is a capillary leakage leading to hypovolemia, hypotension, non-ST elevated MI, and pericardial effusions. Pulmonary, in the same way, there is a capillary leakage leading to pleural effusions, pneumonitis, acute respiratory distress syndrome, atelectasis, etc. Coming to GIT, there may be erosive gastritis, hemorrhagic pancreaticness. So these all are the systemic complications affecting every system. Now the patient presented to you and we diagnosed using laboratory investigations and imaging modalities. And we resuscitated the patient in emergency department. Now, what are the indications for admitting that patient into ICU? If the patient condition is deteriorated even after the initial resuscitation, like the patient is having poor GCS, if still after the initial resuscitation, the mean arterial pressure is less than 50 mmHg or pulse rate less than 40 or more than 150 per minute, if the patient is tachypneic, if patient is hypoxic, the PaO2 less than 50 mmHg, and deranged pH and severe electrolyte abnormalities, if the patient is hyperglycemia, glucose more than 600 milligram per deciliter, or anuria, or if patient with acute severe pancreatitis associated with complications. So these are the indications for admission of patient into ICU. Now, once a patient with acute severe pancreatitis came, this is the approach for the management of acute severe pancreatitis. Initially, airway, if oxygen supplementation is enough, keep the patient on oxygen supplementation, or if required, intubation. Breathing mechanical ventilation with PEEP is required to titrate the recruitment of collapsed lung bases. Now coming to fluid resuscitation. Aggressive management of patients with acute pancreatitis should begin early in the course of disease. And this first 24 hours is referred as golden hours of management. Both under resuscitation or over resuscitation can lead to worse outcomes. So very close monitoring of these patients is needed. Generally, a general approach is to start IV fluids of ringal lactate or normal saline 15 to 20 ml per kg, followed by 2 to 3 ml per kg per hour in the first 24 to 48 hours in patients with hypovolemia. In some other textbooks, they give like initially start with 1000 to 2000 ml of crystalloid fluids, followed by fluid resuscitation at a rate of 250 to 300 ml per hour for 1000 to 3000 ml. But the most important thing is serial measurement of blood urea nitrogen, hematocrit should accompany this fluid resuscitation along with close assessment of clinical condition, vital signs, and urine output. So simultaneous monitoring is very much important along with fluid resuscitation, which includes heart rate, mean arterial pressure, urine output, and blood urea nitrogen and hematocrit levels. After this fluid resuscitation, even there is a rise in hematocrit or blood urea nitrogen during the serial measurements, then again give repeat volume challenge with 2 liter crystalloid followed by 1.5 ml per kg per hour. And in some patients, the systemic inflammatory response syndrome may lead to cardiovascular collapse or SARS-associated cardiomyopathy. So in this patients, inotropic support may be required along with this fluid resuscitation. And in patients with acute pancreatitis, they present with severe abdominal pain. So they should be treated with analgesics, IV fentanyl 20 to 50 mics bolus, or they can be treated with IV hydromorphine or IV mepridine. It is better to avoid morphine because as morphine also causes sphincter body dysfunction. And coming to nutrition, the nutritional therapy in acute pancreatitis, initially it is all about the pancreatic rest. But nowadays, this has significantly evolved from concept of pancreatic rest to efforts directed at early resumption of enteral nutrition. Because enteral nutrition, it maintains gut barrier integrity, it limits bacterial translocation, it decreases catheter-related infection, and it's less expensive. So patients with mild pancreatitis, they can be fed as soon as they're hungry. A low-fat solid diet can be given for them. If patient is moderately severe or severe acute pancreatitis, nutrition can be started within 24 to 48 hours of initial presentation. Only progress to total parenteral nutrition if enteral nutrition has been tried and clearly not indicated. Nutritional requirement as follows: 25 to 35 kilocalories per kg body weight, protein 1 to 1.2 to 1.5 grams per kg, carbohydrate of 3 to 6 grams per kg, and lipids of 2 grams per kg. And coming to antibiotics, according to guidelines from American College of Gastroenterology published in 2013, they suggest Whenever when an infection is suspected, it is justifiable to start antibiotics covering both gram-negative and gram-positive organisms, and they can be discontinued if cultures are negative, but only if there is an infection. But there is no role of prophylactic antibiotics in pancreatitis. So the indications may be any infection of necrotic pancreas, infection of pancreatic pseudocyst, or unrelated extra pancreatic infection. And the antibiotics most commonly used are imipenem, meropenem, metronidazole, and fluoroquinolones. And all other supportive therapy includes antiemetics like ondansetron, metoclopramide. The most ultralight abnormality, as we discussed, is hypocalcemia, should be treated, and hourly blood glucose monitorings. And finally, the ERCP. The role of ERCP is mainly ERCP is limited to patients with acute gallstone pancreatitis with cholangitis. If patients presented to you with acute pancreatitis and biliary sepsis or cholangitis, they should have ERCP performed within 24 hours of admission. If acute pancreatitis is mild interstitial and biliary in origin, it is favorable to proceed this cholecystectomy prior to discharging the patient. If it is moderate to severely pancreatitis, it is better to wait for 4 weeks before performing the procedures. Now coming to treatment of complications. In this also, if this fluid collections are infected, they should be treated with antibiotics. Otherwise, it does not require any antibiotics. So if the in the complications, if it is acute interstitial pancreatic fluid collection, most of the times it resolves spontaneously and does not need any drainage. If it is acute necrotizing fluid pancreatitis, if this is sterile fluid, it can be managed conservatively. If that fluid gets infected, this can be diagnosed by CT scan. In the CT scan, if there is gas within the pancreas, it indicates that fluid gets infected and it should be treated with antibiotics, or necrosectomy should be done. And walled off necrosis, it also occurs after 4 weeks, and it is also diagnosed in CT scan, and percutaneous drainage or transmural endoscopic necrosectomy should be done. So finally, the take-home message of this class is, initially we need to look for clinical presentation, whether the patient is having abdominal pain, epigastric pain associated with nausea, vomiting. Next, laboratory investigations if the serum lipase or amylase levels are elevated or not. Next, imaging modalities to identify the severity in CT scanning. Coming to management, oxygen supplementation and fluid resuscitation is very most important in these patients. And simultaneous monitoring of the patient along with fluid resuscitation is important. Based on that, based on the multiple scoring systems, we need to assess the severity of the patient. And coming to supportive treatment should be given NBM for the first 24 to 48 hours. Initiate enteral nutrition as early as tolerated, and identify and treat the underlying cause. My references are Harrison, O's Intensive and Deranged Physiology. Thank you. Thank you, sir.
Very well presented, Hani Priyanka. You covered up most of the points that are there, and I can see that you made a lot of efforts in researching and making your presentation.
Thank you, sir.
Welcome, Meeta.
Yes, sir. Very nice presentation. I mean, if anyone has not read the topic from anywhere, if they've listened to this lecture very clearly, right from beginning to end, she's covered every single thing which is required to be known. So beautiful presentation, Hani Priyanka, and very smooth presentation. You have understood the subject very well and then presented. So very nice.
Okay, so we'll go on to the question answers. They should be easy to answer because Hani Priyanka has covered them. Now, the first question is that why is oral or enteral feeding superior to TPN in preventing organ failure and mortality, and also in preventing secondary infection of the in the pancreas? So, if you could,
you can raise your hands.
You
and
can
answer.
stop sharing. Okay.
Oh.
So then I can. We can see
Yeah.
everyone.
Repeat the question. Couldn't get the question properly.
Okay, so you can raise your hand, Mehul.
Sir, as early as we start enteral nutrition, it is beneficially because it protects the translocation of gut bacteria, and also it maintains the intestinal barrier.
Very
So,
true. Absolutely correct. By giving anything enterally, even if it is water or it is some food, you don't have to really. It's not about calories and nutrition. You prevent the the lining of the gut from deteriorating, and that favors translocation. So that is the reason that you need to give. You always start with oral first, and if the person cannot tolerate it, then give rest for 1 or 2 days. By third day, you then put in a nasogastric tube and feed in the stomach. Okay, not nasally, jejunal, nasogastric. But when you do nasogastric feeding, you need to monitor the residual feed in the stomach, okay, by aspirating before the next feed. And if the aspirates are not much, you continue nasogastrically. But if the residual fluid is high, then you put in a nasojejunal tube and feed. If despite all this they cannot tolerate, then you have no option but to go for a total parenteral nutrition. Okay. They are one of the most important treatment in the early stages of pancreatitis is fluid resuscitation. So my question is to you is, which fluid should you use and why? Okay, Lalit.
Sir, crystalloid or balanced salt solution?
Beg your pardon?
Sir, crystalloid or balanced salt solution? Like
Okay.
Plasma light.
Okay. Anyone else?
Sir, ringer lactate.
Why?
Because normal saline, it causes the activation of this enzyme trypsinogen into normal saline causing hyperchloremic metabolic acidosis that activates the enzymes, sir.
Yeah, people say that you should give ringer lactate because of this mindset everyone has that giving too much saline is going to give hyperchloremic metabolic acidosis, and they recommend that. But the American Society of Gastroenterology really does not agree with that. They still say ringer lactate is fine. And my personal view is that you are probably in the first 24 hours, you're going to do fluid resuscitation. Okay. Now, what is the normal acid-base balance in patients with pancreatitis? Because of vomiting, and they have metabolic alkalosis. Because of hypovolemia contraction alkalosis, they have metabolic alkalosis. So really, what is the harm of a small amount of metabolic acidosis? So I am not against normal saline being given. So between ringer lactate and saline, whichever is your preference, I think physicians like normal saline, anesthetists like ringer lactate. There.
Sir, what about plasma light?
Look at the cost part of it. I
Yeah.
mean, it's just that it's a costly product without any proved benefit, superiority. So that is it. Now, how, okay, so you decide on what fluid you're going to give, but how do you monitor? Because everyone doesn't require the same amount of fluid. So how are you going to monitor whether you've given enough fluid? What rate would you start it at? Whom will you not give it to? So how will you decide that? These are all practical points.
You can raise hands.
Nita, can you ask whoever's raising hands so that
I'm not able to see here.
okay. So Smita.
Sir, close hemodynamic monitoring should be done whenever we give fluid.
So how will you do that?
And our target should be there, normalization of lactate. Okay. First, we'll give a bolus of 15 ml per kg in first hour. and we'll continue with that. And we'll see respiratory monitoring if the patient is having tachypnea or there are basal crepitations. Is the patient is going into fluid overload, signs of fluid overload, like basal crepitations, tachypnea, desaturation.
Okay. Mehul, do you want to add anything?
Any biochemical parameter?
Sir, I also look for the urine output.
Okay, good.
Also, pain in a pancreatitis because of the ischemia, hypovolemia. So, there is a decrease in the pain also suggests there's a appropriate hydration is going on.
Okay, now there are basically two approaches people have had. One is called the aggressive approach, and the other is goal-directed approach. In the aggressive approach, they give something like 500 ml per hour in the first 24 hours. And so you land up with a lot of fluid going on. I don't think that's a good approach because everyone doesn't require that much. And in goal directed is what Smita was hinting at, that you have some parameters that you're looking at. And also, I think Mehul said that urine output you monitor. The urine output should increase, the heart rate should come down. But most importantly, the hematocrit. You see, most of these patients will have a hematocrit which is very high, 40, 45, 50. And you need to bring the hematocrit down to around 30 to 33. If you do that in the first 24 hours, the prognosis is good. And that has been our experience, Dr. Meeta and myself, that
Yes.
if we can, in interstitial pancreatitis, the most important thing we advise our residents is give fluids going by the hematocrit and try to, in 24 hours, bring the hematocrit down to 30, 33. If you cannot do that, then that means that there is severe ongoing fluid loss, usually because of leaky capillaries, and the prognosis is not as good. People differ in the rate in which some people say 3 ml per kg body weight, some say 5, some say 10, but really it's not a number. Mild pancreatitis will have less fluid loss and they'll require less amount, and more severe ones will require more fluid. So the aggressive approach of giving 500 to a liter per hour to everyone can backfire in some cases. So that's about it. Just 1 second. Hani Priyanka talked about analgesia in pancreatitis because of the pain, and she did mention correctly that morphine is not as good as meperidine or pethidine because meperidine reduces the sphincter of Oddi. It causes relaxation, and therefore it's superior. And she did say the dose 50 to 150 milligram every 3 to 4 hours. Now, Hani Priyanka, you mentioned ERCP as being
Yes.
important in this, but when is ERCP indicated? Not in every case. So, in which cases of acute pancreatitis is ERCP indicated?
So patient with
No, Hani
acute.
Priyanka, you mentioned it, so not for you. You mentioned it in your slide. The answer you
Okay.
gave.
Yeah, she's already mentioned it. Yeah. So from the other students.
Nikunj?
ERCP advised in the case of the obstruction, basically of all blood, duct stone, TBD stone, like
Sir, it is
So
gallbladder
basically,
stone.
yeah. So if there is biliary obstruction or if there is cholangitis, then only you do it. Okay. Now, but the problem is that ERCP itself can cause pancreatitis. Okay. And it can cause complications. So what I want to ask is, how does
What
ERCP?
precaution?
Oh, yeah. How does it cause? First of all, how does it cause damage? How does ERCP cause damage?
Or a very common scenario, patient with pancreatitis and biliary obstruction or cholelithiasis, obstructed CBD undergoes ERCP, and within next 24 hours, patient is into septic shock.
Yes,
What
that is
happened?
true.
What happened here? Why that happened? You relieved the obstruction. You treated the patient, but patient within 24 hours went into septic shock.
Is it they're
Yes.
saying something because your mic is off? I can hear your lips move, but I can see your lips move.
Hello, sir, Dr. Lalit here. Can I speak?
Yeah,
Yeah.
Lalit.
Yes, ERCP is indicated in acute severe pancreatitis with cholecystitis. In case of ERCP, there is a translocation of organism.
No, no,
in
no, no, no. There's no
and
translocation. That's a
instrumentation
translocation is a term for the gut.
and also instrumentation also cause pancreatitis.
Yeah, it can cause bacteria to go into the pancreatic duct. Okay, that's one thing.
Obstruction?
No,
No.
I think
That's
ERC.
inflammation of a duct, sir, possibly cause the obstruction.
No,
There
no,
were
no.
two things. Dr. Mita's question is separate. She says that ERCP is done to tackle the obstruction, and after 1 or 2 days, when the
Within
cholecystectomy
one
is
day,
done,
within 24 hours, patient is into
goes into
septic shock.
shock. Okay, so what was the reason patient went into shock? And what wasn't done, and how could that have been prevented? That is Dr. Mita's question. See, what happens is that the ERCP, when it's done and it causes cholangitis because of the manipulation. And if you don't give antibiotics after ERCP and
No,
you operate
before, prophylactically, sir. You have to
prophylactically,
give 1 hour before at least.
and then when you do cholecystectomy, they go into septic shock because of the bacteria spreading during surgery. My question was that ERCP can cause worsening of the patient by various one. One is direct trauma to the sphincter of OD. If you're doing a sphincterotomy, thermal injuries to the sphincter can occur. If you're doing injection around that area, then chemical injury can occur. So these are all the things. How do you prevent these complications from occurring after ERCP? So there are two methods. What are the two procedures that are done to prevent post ERCP worsening of pancreatitis?
फिर
Hello.
Yes.
चलो नहीं और मना कर रहे हैं तो फिर हो जाने
Zubair, I
Someone's
think there
mic
is
is
some
on.
mic is on. Zubair. Mohammad Zubair. Akhilesh,
Putting a stunt.
putting
वो
a stent
कैश
is one,
पेशेंट है
yes.
वीआईपी रूम क्या करेगा यार
अरे ये जुबैर का माइक ऑफ कर दीजिए ना सर.
Okay. Yes, putting up pancreatic stent is one way. Second,
And sir, pre-procedure antibiotic.
okay, there's one more thing which is done.
Octreotide, sir.
No. It's something that is given rectally. Lalit? Rectal endomethacin is also very popular, and it somehow reduces the complication rate. So that's one more question if you've done on ERCP. Okay. Now, Hani Priyanka said that the amylase and should be raised 3 times the normal. Okay, so in addition to having symptoms of pancreatitis, your amylase and lipase should be 3 times. Now, patient comes to you with the classical presentation of acute pancreatitis, but the amylase is normal, serum amylase. Tell me the possible reasons for a normal amylase. Patient has classical symptoms. The pancreas on ultrasound or imaging is enlarged, so there is no doubt about pancreatitis, but the serum amylase is normal. What could be the reasons? No one?
Sir, may I?
Yeah. Dinesh?
Hypertriglyceridemia. Hypertriglyceridemia.
No, that's a cause of pancreatitis, but that has really nothing to do with the amylase, the story. Akhilesh?
Maybe the amylase, the enzyme not goes within the blood. It is the locally like a.
No, Honey Priyanka told you.
So if pancreatitis is associated with acute mesenteric ischemia?
No. There is pancreatitis, but the amylase is not raised. I will give you one answer. Patient has come after 3-4 days.
Late
The amylase,
presentation.
so slightly late. That is one. What
Chronic
else?
pancreatitis.
And
You're saying it's
acute
a-
and chronic pancreatitis.
So if the pancreatitis is because of alcoholism?
Yes, that's true. In alcoholism, it doesn't increase so much, and especially if it's a female alcoholic. Women who drink the same amount of alcohol as men will not get pancreatitis, but the men will get pancreatitis, and their amylase will increase. So in women, somehow it doesn't rise. If it's very mild pancreatitis, it may not rise. And if the patient comes after 3-4 days. Now, let me ask you another question. Patient's serum amylase is raised, but the CT scan shows no evidence of pancreatitis. What could be the reason?
But it could be acute cholecystitis, and amylase can be raised in
Yes,
cholecystitis.
that's one. Very true. Acute cholecystitis.
Hyperamylasemia.
Due to
Because
what?
of what?
Small bowel obstruction.
Yes. Small bowel obstruction is also correct. What else?
Perforated ulcer of gastric or duodenum.
Very true. Perforated ulcer. What else?
Intestinal ischemia.
Intestinal
Mesenteric
ischemia.
ischemia.
Okay, who is answering this? Who answered this?
Sir, me, Adit.
Adit, you aren't Googling and telling me the answers, no?
No, sir.
Okay. All right. Okay,
He's
very
read
well
and
done.
probably.
No, that's good. So basically, anything around the pancreas, the gallbladder inflammation, the small bowel obstruction, that's especially
Stomach.
duodenal obstruction,
Ulcers.
perforated ulcer, gut ischemia. So all those can also cause it. And also, though it's not mentioned in the books, renal failure can cause amylase to be a little high and not be there. What is the indication for ultrasound in a patient of suspected pancreatitis? When should you do an ultrasound?
When we get gallstone.
Gallstone disease to rule
So
out.
how do you know there is a gallstone?
Sign symptoms.
Okay, if you basically, I think whenever there's a first attack of acute pancreatitis, you should do ultrasound of the abdomen the first time patient presents, because clinically
Yeah, so first
picking up
time you
gallstone.
suspect pancreatitis. Yeah, first time suspected pancreatitis, you should straight away go and do sonography.
Yeah, just sonography, not a CT scan. Do a sonography to look at gallstones. Then you will know that there is. And you will pick up gallstones. You may not pick up anything in the duct or anything, but it that's the indication. So you rule out gallstones, you rule out bile duct stenosis, you can rule out dilatation of the bile duct, but that's about it. When would you advise, see, ultrasound? The problem with ultrasound is gas in the stomach can interfere with your pickup. So people have advised endoscopic ultrasound there. So when would you advise endoscopic ultrasound?
Then it is more for like biliary causes if we want to diagnose.
No, biliary
No,
causes
no.
is not an
Endoscopic
indication.
ultrasound. We are not talking about ERCP. We are talking about endoscopic ultrasound.
Ultrasound. Endoscopic ultrasound.
So when we are suspecting air in the abdominal cavity, free gas, where which will be hampering ultrasonic view.
In case
So,
of malignant etiology.
No, not really in those cases, because the indication for endoscopic ultrasound is if you could not find a cause of, so you label it idiopathic, but the pancreatitis is recurrent. So recurrent idiopathic pancreatitis, then you do an endoscopic ultrasound because you can pick up very minute problems of the, especially abnormalities at the sphincter of Oda. And also you can pick up microlithiasis. Okay, so that's when you will do it. Otherwise, you do not do this ultrasound. What is the indication for CT scan? When will you do a CT scan? In a patient with acute pancreatitis.
This is very common practical question.
When diagnosis is not
So
certain.
diagnosis is unclear, and
Okay.
who portrays to improve clinically within 24 to 48 hours of even in spite of treatment, sir? Or
Yes,
after
COVID.
hospital examination?
What?
Or deterioration.
Or
Yeah.
sir, to know the extent of the
clinical
disease,
deterioration.
Sir, for severity scoring.
to know the extent of pancreatic disease.
No,
No,
did you have
severity
severity
scoring.
scoring means CT scan? Did you have that?
No, not for
So,
severity.
No, that's wrong answer.
so patient is deteriorating.
Despite treatment.
Despite
So
treatment.
extent of
So-
disease, to know the extent how
Not
Not
really.
not really. Diagnostic uncertainty, especially when your amylase, lipase, and the radiological picture is not correlating, then you do it. So your amylase and the symptoms and everything don't correlate. If you suspect local complications, you can do it. Okay, so these are some of the indications. You don't do it
And
in
they
every
said
case.
some of them, if the patient is not improving despite treatment, then you can do it. If patient is deteriorating or has started developing another organ involvement, then you can do it.
Okay,
It's not a
now,
routine investigation to do CT scan to confirm, unless you are in doubt.
okay, now the CT scan shows peripancreatic collection, and the surgeon wants to operate on his patient. Have you understood? CT scan is done, it shows peripancreatic collection, the surgeon wants to operate. What would your suggestions or discussion with the surgeon be? When will you say that it is advisable? He wants to operate.
So
He's
basically,
getting money.
appropriate timing of
Sir.
intervention.
After 4 weeks, normally.
Sir,
No, that's not a correct answer.
If the collection is infected or necrosed.
infected,
Yes,
sir.
one
If
is
it is
very
infected
important.
pancreatic.
If it's infected fluid, so how will you know if it is
And
infected or
second-
not?
By draining it and doing culture.
You are not settling down.
5
Counts
minute
are-
respiration, 5 minute respiration, ultrasound.
No, there's only one way. There are two ways. One is you do a
Good counting.
fine needle aspiration and a gram stain. If you find organisms, then that is an indication that it is infected. Second, on a CT scan, if you see air bubbles, okay, if you see air in the fluid, it means that there is gas-producing organisms, and that is a sign of infection. So the one is infected fluid, you will operate. Second, if there's a pseudocyst which is symptomatic.
Intra-abdominal pressures are raised and it is causing
Compartment syndrome or gastric
No,
outlet
if there are
obstruction.
2-3 people speaking, I can't understand.
Sir, local signs symptoms like gastric outlet obstruction and it causing the raising the intra-abdominal pressures also, sir, which can.
No, you're right, partially right. If there is a pseudocyst and that is causing a pressure on the duodenum, pressure on the stomach, pressure somewhere. If you're getting pressure symptoms, okay, then you can operate. But otherwise, it's not, as Hani Priyanka said, that for even if it's necrotic collection, but it is sterile, you want to wait and watch. Hani Priyanka already said, how are they classified? Mild, moderate, severe. She did say that. How does alcohol cause pancreatitis? What's the mechanism?
May I, sir? Sir, it
Who is this?
causes
Jaipal? No. Who is that?
Rajkumar, sir.
Rajkumar. Yeah, tell me, Rajkumar.
It causes the increase in bicarbonate secretion, which blocks the ducts and which causes the back pressure change in the SNI, which leads to release of the some enzymes.
I don't know what you said about bicarbonate, but you're partly correct that alcohol causes increase in the viscosity.
Thick secretion.
Yeah, it causes thick secretions, and they cause and thick secretions lead to protein plugs in the duct, and therefore there is back pressure. Okay, that's one mechanism. Second is there's a direct toxic effect of alcohol on the pancreatic cells.
The metabolic products, they cause toxic effects. Metabolism of alcohol.
Yes, ma'am. Yeah.
The third is that alcohol itself causes change in the gut flora, and therefore gut toxins get absorbed, and they can damage the pancreatic acinar cells. There is a genetic predisposition also, because everyone drinking the same amount of alcohol doesn't get pancreatitis, and especially somehow women are more resistant to getting pancreatitis.
Sir, आज आप take home message क्या दे रहे हो, by the way?
I'm surprised why women don't get pancreatitis as much. What else can I say? Honey Priyanka mentioned this, but I'm just asking, how do gallstones cause pancreatitis?
It's simple, most simplest question.
Obstruction, obstruction ampulla filter, and that causes back pressure on pancreatic.
Yeah, I wouldn't ask that question if that was the only thing. Trypsin gets chymotrypsin, they get activated when they reach the gut. But because of obstruction, they get activated in the pancreatic duct and the interstitial cells of the pancreas, and therefore there is autolysis occurring. It's the fact that the trypsinogen and trypsin gets activated in the before reaching the duodenum. Which drugs can cause pancreatitis?
Thiazide diuretic,
Thiazide, loop
thiazide diuretic, ethacrylic acid,
Some
furosemide.
antibiotics also.
All diuretics.
Tetracycline.
Valproate.
Pentamidine.
Yes, pentamidine can.
Steroids, sir.
Valproic
Steroids,
acid.
I don't know.
Estrogen.
Azathioprine, sulfine tetracycline, and estrogen are the common ones that can cause. Just 1 second, let me see what else. Why are patients with pancreatitis hypovolemic? What are the mechanism of hypovolemia in pancreatitis?
Increased capillary
Capillary
permeability.
leakage, excessive fluid loss.
Increased capillary permeability.
Okay, that is one.
Increased capillary permeability that cause excessive fluid, extracellular fluid loss, and
Okay, that's the last mechanism.
Patient is not able to take orally, vomiting.
Yeah, nausea. First of all, nausea. Person is not taking fluids. Then vomiting. So there's direct loss of fluid. 3 is the local complication. There's a loss of this collection of fluid in this abdomen, including ascites and retroperitoneal fluid collection. So that, and finally leaky capillaries. So there's a diffuse fluid loss all over, including the lungs, causing ARDS. So it's multifactorial. More common than leaks are nausea and vomiting. Will lead to this. 1 second. Okay, let me. How will you? Okay, now listen to these last 3 cases. These are cases. 36-year-old male presents with acute pancreatitis. since 2 days. He complains of nausea, vomiting, and pain in abdomen. His alkaline phosphatase is raised, SGOT, SGPT is raised, and serum bilirubin is 1.8. After treating with hydration, and analgesia, over next 2 days, he recovers. His vitals become normal. Alkaline phosphatase becomes normal. ALT, AST become normal, and bilirubin drops to 0.7. Okay, ultrasound of the abdomen shows multiple gallstones and a normal common bile duct. What will be your next step in management?
Hani Priyanka already covered, but those who are awake will tell.
ERCP.
If pancreatitis is mild, then we can go ahead to cholecystectomy in same setting. If moderate to severe pancreatitis, then we have to wait for 4 to 6 weeks.
Exactly. Who is this?
For cholecystectomy.
Who is answering?
Sir, Dinesh.
Dinesh, you're absolutely bang on, Dinesh, that since this was mild, within 48 hours, the patient improved, okay, and there's no local or systemic complication. Then in the same admission, you will not discharge the patient, you will, and there is gallstones, so you will go for cholecystectomy. That's absolutely correct answer. Okay, now the next question. Which of the following are recommended in the management of acute pancreatitis? So patient comes with acute pancreatitis. Which of the following are recommendations? 1, ERCP drainage of pancreatic pseudocyst, oral feeding as soon as patient tolerates, nasovaginal feeding, or prophylactic antibiotic.
Oral feeding.
Oral
Yeah.
Absolutely. Absolutely. Oral feeding. Endoscopic drainage of pancreatic pseudocyst. Do you know why pseudocysts are formed? There is leak from the pancreatic duct and the digestive enzymes are collected because of the disruption of the pancreatic duct. Okay. So unless there are pressures, effects locally, you don't do anything for that. And the correct treatment, of course, was this. Last question. A 40-year-old obese female is admitted with 3 days of worsening epigastric pain radiating to the back, nausea, vomiting, so pancreatitis. She is afebrile, blood pressure is normal, pulse is 110, abdomen is soft, there's mild epigastric tenderness, white cell count is 7,000, hematocrit is 48%, BUN is 25, serum lipase is 1,500, normal is less than 120. What is the next step in management? Will you do ultrasound abdomen? Will you do CT scan abdomen? Will you do endoscopic ultrasound? Or will you do MRI cholangiopancreatography?
USG whole abdomen.
USG
abdomen.
Yes, absolutely correct. You do USG abdomen. Okay. CT scan, there's no indication, no local complications, etc. Endoscopic USG is only for recurrent idiopathic, and MRI you don't need to do so. Those were
Well
the
done.
questions.
Well done, all of you.